Hi, everybody. Welcome to the Breaking Barriers to Access Critical Health Information, Reaching the Limited English Proficient Population During COVID-19. We are very happy that you have joined us. And my name is Joanna DeBow. I am from Brooksea, Nesta. And our guest speaker today is Pooja Chandrasekhar. All right, we're going to go ahead and get started. Pooja is a first-year medical student at Harvard Medical School. She graduated from Harvard College with an AB in biomedical engineering and subsequently completed a Fulbright scholarship in India. Alongside clinical medicine, she is passionate about improving the quality and delivery of healthcare and hopes to leverage emerging technologies and policy levers to transform care for underserved populations. Her current research focus on using data analytics and informatics to measure the cost, quality, and appropriateness of care and inform the development of high-performing health systems and equitable policies. She also serves as a managing assistant editor for Healthcare, the Journal of Delivery Science and Innovation, a peer-reviewed journal of healthcare delivery science published in Elsevier. Pooja has broad experience in health services and policy research at the organizational, state, and federal levels. She has worked on the merit-based incentive payment system at the U.S. Department of Health and Human Services, digital health strategies and policy at the National Health Service in England, and community hospital reinvestment programs at the Massachusetts Health Policy Commission. Pooja's work in healthcare information technology includes research at Boston Children's Hospital on using social media data to understand population-level health trends and research at the Mites Corporation on developing a rapid screening method for the diagnosis of mild traumatic brain injury among athletes and military personnel. As a champion of education equity, Pooja is the founder and CEO of Project Girl, an international nonprofit dedicated to encouraging middle school girls to pursue technology and computer science. She also serves on the board of She Rocks the World, and now is also the founder and director of the COVID-19 Health Literacy Project that we'll be speaking today. Thank you, Pooja. So the quick guidelines, just so you know, all the telephone lines will be placed on mute and today's session is being recorded. The questions will be answered throughout the presentation and during a Q&A and session at the end. Please use the chat box to send us your questions and make comments. We will be monitoring it during the whole presentation. Our program, CPA for Health Equity, is to build the capacity of leaders, staff with community-based health settings to identify and address health inequities at the organizational or community-wide level. Please follow us on our social media and use our hashtag ProceedCPA for Equity. So let's go ahead and get started and get to know each other. I'm going to launch a few poll questions. First, we would like to know, where are you located? So please take a few seconds. All right, a few more seconds left. All right, 3 more seconds. All right, so 81% of attendees are from the Northeast region. We also have 10% for the Caribbean and a few people from the West, Midwest, and South. Next, we would like to know, which type of organization do you represent? Hospital, community-based organizations, government agencies, all levels, healthcare, or other. If you are in another, please use the chat box. All right, a few more seconds. All right, 2 more seconds. All right, we see here 35% of you are from a community-based organization and from a government agency. We also have 14% from hospital medical group practices and 8% for either healthcare clinic or another. And some of the others, we have a university-based dental clinic. Okay, and our last poll question is, we would like to know what group describes best your job title, if you are in the part of the leadership, mid-management, frontline, clinical, or non-clinical, or other. All right, a few more seconds left. Okay, I'm going to close the poll. And we have 38% leadership, 32% mid-management, 21% non-clinical frontline, 3% frontline, and 6% other. And from the other, we see somebody from a public health program analyst. So thank you very much. Our program objectives are right here. We're going to be focusing on the COVID-19 Health Literacy Project, as well as talking a little bit about the LEP population in the U.S. Today's session agenda is right here. And let's go ahead and get right started. I want to make sure that you are able to see the change of the screens. I have a message earlier saying that you cannot. So please let me know if you're able to see the slide with the limited English proficiency population in the United States. All right, great. Thank you so much, Giselle. Okay, so we can understand the importance of having language services offered. We must analyze the demographics of this population that will be mostly affected by these services. Let's start by defining LEP. The term limited English proficient, LEP, refers to any person aged 5 or older who reported speaking less than very well as classified by the U.S. Census. The term English proficient refers to people who report speaking English only or very well English. Keeping this in mind, let's explore a little bit more about this population in our country. Out of the 327 million people living in the United States in 2010, 40 million or 12.7% were foreign-born residents. If we include also U.S.-born residents, 57 million or 20.6% claim to speak a language other than English at home. This number increased to approximately 61 million residents by 2013, showing that the trend seems to increase over time. Of this population, 25.2 million or 8.7% claim to speak English less than very well, hence being our LEPs. Although there are over 300 languages spoken in the U.S., the top languages are shown here, and they include Spanish, Vietnamese, Chinese, Portuguese, African language, Korean, Russian, Creole, and Arabic. It is important to note that because each state has a different population demographic, each organization should do an assessment to understand the diversity of the community they're serving. So all the recommendations need to be targeted to your particular population. Here you can see the map of the U.S. and how it has increased throughout the years in regards to the LEP population. The biggest change has occurred between 1990 and 2010, although soon hopefully we'll have the new updated census data. If you look at the map, The states with the biggest growth of LEP population are numbered, and they are, starting with number 1, Nevada, with a growth of 398%, North Carolina, Georgia, Arkansas, Tennessee, Nebraska, South Carolina, Utah, Washington, and Alabama with 202% increase. Now, if you look at the states in the map in the dark blue, those are the states where at least 10% of the population is LEP. This is in contrast to the average 8% nationwide. And these states from the top are California with 19.8%, Texas and New York with 14%, New Jersey, Nevada, Florida, and Hawaii with 13%, and Arizona with 10%. Among the LEP population, the two largest groups are Latinos at 63% and Asians at 21%. The age range of this population includes 75% of working age 18 to 64 years, 50% are seniors, and 10% are school age 5 to 17 years. It is important to note that out of the LEP children population, 77% are U.S.-born children, most of them first-generation Americans, in comparison to only 50% immigrants and 2% U.S.-born residents when referred to adults. So other characteristics that are important to note from 2016 include that of the 51.3 million children ages 5 to 17 in the U.S., 8 million, or 60%, live with at least one LEP parent. LEPs are more likely to not have a high school diploma by age 25, and they're also less likely to have a bachelor's degree or higher at a rate of 14% compared with 31% of their English proficient counterparts. Although 25% of LEP individuals live in households with an annual income below the official federal poverty line. This is twice as high as the share of the English proficient immigrants at 14%. And finally, speaking of health, compared to English-speaking patients, LEP patients report 44.9% low health literacy versus the 13.8% of English speakers. So this study here represents an example of how the lack of language services can compromise patient safety in regards to healthcare quality. In 2005, 6 hospitals were followed for 7 months, and 1,083 adverse incident reports were analyzed and compared with the LEP versus the English-speaking patients. This study found that 49% LEP patients experienced physical harm versus 29.5% of English speakers. 46% of LEP patients had higher levels of physical harm ranging from moderate temporary harm to death. And 52.4% of adverse events for LEP patients were communication errors. So now I have a quick poll here. I would like to know if you think this is a true or false question. There are laws and regulations that require the use of interpreting and translation services. Okay, 4 more seconds. All right, I'm going to close the poll. All right, and most of you say that this is true. And yes, there are laws and regulations that require healthcare providers to offer free of charge language services to the LEP population. Okay. So some of these regulations are basically saying that under the ACA, any covered entity needs to provide quality service languages, and this includes both oral and written documentation. So a quick summary of what is appropriate and what is not and what is expected from these regulations is that individuals should be provided with interpreting and language services on their preferred language. We should not be charging individuals for these services. We should require that professionals are performing this to make sure that there is quality services, and do not use minor children or family members unless it's absolutely necessary for family members, not children, and require individuals to provide his or her own interpreter. So a quick FAQ questions. Let me see if there's anything on the chat. If you have any questions, please go ahead and use the chat. This is a good time to take a break and answer some questions. So a lot of the questions that we get are, what is the threshold for providing language services under ACA? And what about best practices? So the threshold for this is more than 10% of non-English speaking individuals in a county, then you have to provide services in that specific language. Another question that we get is, what can we do in my organization to make sure we provide quality language services to our clients? So to make sure your organization performs this type of services, make sure that you perform community assessments to identify the language needs, train your employees on cultural competence, and provide quality language services. If you have any questions about this, please contact us after the webinar, and we'll be more than happy to expand and provide some services for you if needed. And the last question that we get a lot is, what are some of the benefits of providing quality language services for the LEP population? And there are a lot of benefits for this, but few of them are an increased patient satisfaction and health outcome, reduced readmission rates, improved patient safety outcomes, improved efficiency of care services, avoids lawsuit-related languages, and decreased bad debt, as patients are able to really understand what their financial requirements and expectations are from your services. So is there any questions? Okay, I don't see that there are any questions right now, so great. So we'll continue. And now our guest speaker, Pooja Chandrasekhar, will be presenting her project. So Pooja, please, your microphone is all yours.
All right, can you all hear me now?
Yes, we can.
Perfect. Thank you so much for having me, Joanna. Hi, everybody. So as Joanna mentioned, my name is Pooja Chandrasekhar, and I'm a medical student at Harvard Medical School, as well as the founder and director of the COVID-19 Health Literacy Project. So today I'll be speaking to you about how the COVID-19 Health Literacy Project is tackling the barriers that Joanna just described, and how our efforts are designed to reach the limited English proficiency population during COVID-19. And it's important for me to emphasize here that today's discussion is centered around COVID-19, but the takeaways regarding the importance of language accessibility are broadly applicable. And we hope that those of you listening today, or those of you who will be watching later, can take what we discuss back to your organizations and make language accessibility a priority as we work towards our shared vision of health equity. So before I get into the meat of what the project is, I want to speak a bit about the motivation, and so share the reason that I started the COVID-19 Health Literacy Project. So the motivation was due to a real need in the community. I'm based in Boston, and as the coronavirus began picking up steam here in Boston, I began speaking with a few local community-based organizations. And one of these was the Family Van. And the Family Van is a mobile health clinic that serves predominantly immigrant, refugee, and minority populations in the greater Boston area. And the family van is a physical van that drives around the greater Boston area and provides basic primary care services to communities in need. And you can see here in this image, community members lining up to access the free health screenings that the family van staff provide. You can imagine now that given the populations the family van serves, many of their patients are not native English speakers. And the clinic staff, as I spoke to them, described being unable to provide these patients with materials or information in their native language. And without access to materials in their native language, it made it incredibly difficult for these patients to know when and how to seek care. Ultimately, this made it challenging for these patients to know how to protect themselves and their communities, thus placing them at a higher risk of infection from coronavirus. Now, though this story that I just shared was rooted in Boston, by no means the lack of language appropriate health information a local or state problem. For sure, some state health departments are doing better than others in providing access to multilingual COVID-19 information, but the reality is that this is the national problems, and these headlines illustrate that. Around the country, existing language barriers have become even more dire amid the outbreak. And hospitals without multilingual materials or interpreters have left non-English speaking patients feeling alone, confused, or without proper care, as this ProPublica headline so aptly summarizes. Now, in addition to these impacts, we also know from past epidemics that language barriers have a real impact on patients' health and on health disparities in general. So we know from the swine flu epidemic of 1918 that individuals with low literacy are more likely to transmit and die from infection. Similarly, in the H1N1 flu outbreak of 2009, we know that non-native English speakers are less likely to receive information from the public healthcare system, and this places them directly at a higher risk of exposure. So the point is that the lack of access to health information in one's native language is a structural barrier, and it's one that places non-English speakers at a higher risk of infection and directly exacerbates health disparities. So when we're thinking about this problem, we want to think about it not only from a public health angle, but also from the real and insidious clinical impacts of not being able to access information in a language that you speak and understand. So do we have a poll here? Okay.
Yes, we're going to run a quick poll. So we wanted to know if language barriers increase the risk of infection for non-English speakers. Is it true or false? All right, a few more seconds. Okay, I'm closing the poll. So what we see here is 95% say that it's true and 5% it is false. Thank you, Pooja.
Great, thank you, Joanna. So now I'm going to continue. All right, perfect. All right, so I started the COVID-19 Health Literacy Project to close these gaps in COVID-19 information and make sure that nobody is left on the sidelines of this global pandemic. So our mission in summary is up here, and it's to create and translate accessible, evidence-based COVID-19 information into 40+ languages to help everybody, especially immigrants and non-English speakers, stay informed and healthy. And our materials are produced in collaboration with Harvard Health Publishing, and I'll speak a bit about what exactly that translates to in addition to just the added credibility and validity that comes from that collaboration. Now, before I show you what these materials look like, I wanted to spend some time talking about okay, great. before I show you what these materials look like, I want to spend some time talking about the process to produce these materials. So in addition to just kind of giving you an insight into what happened behind the scenes, I think it's also important to provide you all with a roadmap that you can use to implement similar initiatives to increase language accessibility both during and after this pandemic. So for us, it all started with a call to action on Twitter. So here you can see this is just a tweet that I put out about a month and a half ago, and I ended up receiving over 300 responses from medical students around the country. And these students were eager to help and contribute their time and energy to this cause. And ultimately, I ended up recruiting around 175 medical students from 30 plus academic medical institutions around the country. And together, they collectively spoke over 40 languages. Now, it's also important for me to emphasize here that although this was a grassroots student-led effort, faculty support was crucial. And we had over 40 infectious disease and primary care physicians who were involved with vetting the materials and the translations, and making sure that the materials we're providing the general public are consistent with the highest clinical and quality standards. So once I put this team together, the next step was to create the actual English fact sheets. And we decided that our fact sheets should be one-pagers, such that they were easy to understand by patients with lower levels of health literacy. So what we started to do was we looked at the evidence-based information that was already out there. So what was the information that was released to the public by health agencies like the CDC and the WHO? And then how can we take this information, it's evidence-based, vetted information, and distill it down into something that's accessible and understandable by folks with lower levels of literacy? So to do this, we considered a lot of questions, but we tried to distill it down into these 4 really important questions that we thought captured a lot of the nuances that are involved with doing something like this. So reliability, importance, accessibility, and tone. So reliability, is the information from a reliable source? So some agency like the CDC or the WHO. Again, getting at that idea that we want to make sure that we're providing only the highest quality, accurate information to the general public. Second question is importance. So this is getting at that issue of information overload. And we want to make sure that when we're creating these one-pagers, we are only including the information that is necessary. And we're including all of the information that's necessary, but we're not putting so much out there that it's then becomes difficult for somebody reading to sift through and know what to take away. Then accessibility, is the information easy to understand? So is the content and text presented, is it easy for somebody to grasp and really get their head around quickly? And lastly, tone. And this is something that I think gets pushed to the sidelines often, but we found it was really critical. And so here we're getting at the idea that along with the content, are we presenting the information in a way that it's both actionable and also reassuring to somebody reading? So on this slide, you can see what our English fact sheets look like. So ultimately, we decided to produce a okay. How do I go back to the slide? Perfect, thank you. So on the slide, you can see what our English fact sheets look like. And ultimately, what we decided to do is we decided to produce a total of 7 one-pager fact sheets, 4 that are geared towards adults and 3 that are geared towards children. And the 4 for adults, which are the ones that you can see on this slide, cover prevention about COVID-19, management of COVID-19, and pregnancy and COVID-19. So the prevention sheet includes information on best practices for preventing the spread of COVID-19 and protecting yourself. The about sheet includes basic information on what coronavirus is. The third, or the management fact sheet, explains what to do if you are sick with COVID-19 or suspect you're infected. And it also includes a list of concerning symptoms that should prompt you to seek medical care immediately. And the pregnancy sheet is more of an FAQ style sheet for those who are pregnant or planning to become pregnant during the COVID era, because as you might suspect, that raises a lot of questions and a lot of worries around what to do in that situation. And on this next slide, you can see our 3 fact sheets that are designed to explain coronavirus to kids at 3 different age groups: 3 to 6-year-olds, 6 to 12-year-olds, and 13 to 18-year-olds. So we really were keen on doing this children's fact sheet piece because what we realized as a team were that, kids are at home, they're out of school, have a lot of questions about what's going on in the world around them and why our society has just suddenly changed to function the way it's functioning right now. And we think that it's only fair that we are able to provide information to kids to reassure them and address the worries that they rightfully have. So we designed these fact sheets in collaboration with physicians at Boston Children's Hospital. And the reason that we worked on these so closely with pediatricians and social workers and educators was to make sure that they were developmentally accurate, developmentally appropriate, consistent with principles of trauma-informed care and education, and easy to use by both parents and fun for kids to learn from. So there are a lot of these particular questions and nuances that you need to be aware of when you're designing materials for kids. And so for those reasons, it was really critical for us to work with pediatricians at every stage of the design process. And as we designed these children's fact sheets, we placed near equal emphasis on the design in addition to the content. And you can start to see some of the approaches we took here. I won't go into them in detail, but I just want to call them out. For example, bright colors, icons, diverse graphics, using layouts tailored for the appropriate age audience. So for example, you can see the 13 to 18-year-old sheet looks really different from the other 2. And the reason is we used a magazine layout for the 13 to 18-year-old sheet because education research shows that teenagers tend to better engage with layouts like those in the magazines that they read outside of school. So you can just get a sense of what are all of these other questions that you need to be considering when you start to do language accessibility work. And after we created the English fact sheets, the next step was translation. So for us, we were translating them into over 40 languages. So up here, you can see a list of some of the languages that are currently available on our website. And we're adding more every day. And we add more every day as and when organizations or community members reach out to us to ask to add another language to our list, and depending on whether or not we can find folks to translate our materials, and also whether we can find physicians to review our materials. And maybe in the chat box here, if you don't see a language that you would like to be represented, I would love for you to put that language up in the chat box, and we can try our best to incorporate it into our resource. So just to clarify here, the translations were, for us, the first line translations were completed by medical students who were native speakers of that language. And then each translation was proofread and edited by a physician at Harvard Medical School who is a native speaker of that language. So that check was really critical for us, that we were making sure that our translations were accurate and really consistent with both language and cultural standards. So now, as we progressed, we realized that our materials are, okay, great, perfect, thank you. So now, as we progressed, we realized that our materials are well suited for folks with lower levels of health literacy. But then we started thinking about, what about populations with little to no literacy? How do we make sure that public health initiatives like ours aren't neglecting the needs of this substantial population with nearly no literacy? So we realized that in order to reach these populations and be as inclusive and accessible as possible, we needed to create a set of no text infographics. and you can see them here. So on the left is a strip that corresponds to our 4 fact sheets for adults. And on the right are 3 infographics that each correspond to our children's fact sheets. So our intent was to use clear, easy to grasp images to tell a story and share the same information that was included in our fact sheets, but in a visual format rather than one that included any text. So now, as an organization, our intent was to make sure that these materials are as accessible as possible. So all of our fact sheets are freely available for download and distribution on our website. Just try to navigate to the next slide. Okay, thank you. So the link is here. That's what our homepage looks like. And our fact sheets are all available for free download and distribution. And you are welcome and encouraged to please download and distribute them to your communities as well. Again, getting this idea that how do you make sure that the information and materials you're creating are as easy to access by those in the community. So now that we've, I've walked you through the process of the motivation, the design, the translation, the last step was getting our materials to the communities that need them. And we do this by working with community partners who disseminate our materials to the communities that they serve already. So we work with organizations that span the gamut from hospitals and health systems to clinics and cities and public health departments to then advocacy groups and community-based organizations. So I've just put a few up here on this slide so that you have a sense of the diversity of the organizations that we work with and the different types of communities that they serve. And the main takeaway here is that the reality is that COVID-19 is a thorny, multifaceted public health crisis, and we need all hands on deck to tackle a crisis like this. Language accessibility is critical for nearly every effort to combat coronavirus, whether that's a policy brief or whether that's an academic research study or whether that's a community pamphlet that's being distributed in the community. So our strategy is to distribute our materials to groups across the board. But as you might be able to tell from the names of the groups that are up here, we do have a focus on groups that serve immigrant, underserved, or minority populations. And again, the way that organizations can partner with us is simply by contacting us through our website, simply by contacting our team members. So we have a very open door policy for partnerships. It's not like we're only targeting certain groups over others. We're really trying our best to cast as broad of a net as possible. So now I wanted to end by highlighting some of the unique ways that our partners are utilizing our materials and how they're integrating them into their existing outreach and clinical care models. So I'm just gonna, describe a few of these stories so that you can get a sense of the really fantastic work that our partners are doing. So for example, our fact sheets are being distributed to Feeding America's 200 affiliated food banks and 60,000 agency partners. Our fact sheets are also being included in the family vans, patient outreach. They're being placed in, physical copies are being placed in the Dropbox that are then distributed to patients. And they're also being shared with the 2,000 plus participating mobile clinics that are part of their network of mobile health clinics called Mobile Health Map. And that's a national network. Our fact sheets are also being shared with Heartland Alliance International program participants, and HAI is a Chicago-based organization with international chapters as well. And HAI serves poor, displaced, and endangered populations. Our fact sheets are also being distributed to English as a second language students and Action for Boston Community Development. Our fact sheets are being distributed to patients at the OB-GYN Center at Abington Memorial Hospital in New York. This center serves primarily uninsured and underinsured women. And finally, they're being distributed to Ariadne Labs, 32,000 plus affiliated clinicians in over 150 countries. So you can see that This issue is really interdisciplinary and really multifaceted. And we strongly believe that only by tackling these gaps in information from all angles, including policy, institutional, and clinical, can we begin to bridge them. So with that, I'd like to end my presentation. And I think we also have a few FAQs up here that I'm going to quickly answer, and then I'll open it up to you all for controls for the remainder of the session. But let me just answer these. Do you want me to just go into the FAQs quickly, Joanna?
Yeah, I was going to say it's a good time to ask questions. In the meantime, while you type, I'm going to go ahead and ask you this 2 FAQs, and then you can go ahead and answer. So the first one is, how do you ensure that the translations are also culturally appropriate in addition to linguistically appropriate?
Yeah, so this is a really key question here. So I'm going to use an example to illustrate how we do this. So for example, in our children's fact sheets, we had a piece that said it referenced the happy birthday song, referenced Baby Shark as a way for kids to know how long to wash their hands for. But when we were doing the translations, some of our translators mentioned that, those names of songs don't really make sense in different languages, in the language that they speak or their family members speak. So what we ended up doing was switching the text around, substituting something similar, substituting something from that particular culture that would make more sense and convey the same message. So we really tried to incorporate as much of this feedback around cultural sensitivity as we could, because we strongly believe that if information isn't culturally appropriate in addition to being linguistically appropriate, then you're not actually going to be able to have community members from that culture be fully engaged with it. So we tried to do this through a combination of text-based changes, through content changes, through wording changes, etc. So through a lot of different combination of things, but again, being very mindful of what native speakers thought and what the feedback they provided to us and acting on that feedback.
Great, thank you. This is so very important. The next question is, what is the vetting process for the materials provided by the project? Yeah. And I want to go ahead and tag another question that we just received from Giselle Pemberton. She says, can you expand on how you approach developing materials for folks who aren't literate? Can you describe the development testing process, which is a little bit of this?
Yeah, so let me answer the vetting process question first. So the vetting process, I just want to highlight what I had mentioned before already, which is that all of our materials are reviewed and vetted by physicians and faculty members at Harvard Medical School. So both the English content is reviewed and approved by physicians, and also the translations themselves are proofread and edited by physicians who are native speakers of that language. So both the content and the translations, and this is what allows us to collaborate with Harvard Health Publishing, which is the group that I mentioned in the very beginning of the talk. So this vetting process is really critical to making sure that we are producing and disseminating materials that are accurate and reliable to the communities that need them. And the question that you asked was about, if I'm correct, about the process for producing the materials for illiterate populations?
Correct.
Yeah, okay. So I believe that question then focuses on the no-text infographics. So the process for developing the no-text infographics, so we actually worked with folks from Boston University on this, and from both the medical school and their fine arts school. So we had a lot of input from both medical professionals and also from design professionals. And I think this collaboration was really critical to making sure that these materials were, appropriate and accessible to populations. And again, they were all reviewed by physicians, et cetera, to make sure that they are, understandable and also appropriate, conveying accurate information.
Great. So everybody knows we are open to questions, so please go ahead and type them on the chat box. Right now we already have 2. Pooja, Brenda Cruz is asking, do you have any plans of shifting your efforts and developing new educational materials that are also developmentally appropriate related to transitioning back to work, school, houses of worship, etc.?
Yeah, great question. So that's definitely something on our radar right now. We're actually, we as a team have been discussing next steps, and this is exactly something that we're focusing our attention on right now, is how do we support folks in knowing when is it safe to return to quote unquote normalcy, and how do we, best convey information, because there's a lot of misinformation circulating about stay-at-home orders and when they're being lifted and when to wear masks and when to not wear masks. So that's definitely something. Thank you for highlighting that and asking that question. Yes, the answer is yes. We're definitely in the process of thinking about that. We haven't made a decision yet regarding exactly how we intend to approach that, but we will certainly be doing something in that arena. And I would encourage you to check out our website or stay in touch with us via our social media to keep abreast of new developments as they come in.
Thank you. And we have put in the chat box also the link to your website, so people can go ahead and click on it. We have a question here from Krista Real. Do you work with any health educators or health communication specialists in developing materials?
Yes, so both actually. We have worked, so like I said, all of our materials are developed in collaboration with physicians, so health educators, and they are, and that also includes health communication specialists from also affiliated with Harvard.
Great. If anybody has questions, please, this is a good time to add it in your chat box. I wanted to give you some feedback that we received from when you had the slides of the kids infographics. Somebody says that on the 13 to 18-year-old document under what is COVID-19, you say it's a virus, but COVID-19 is a disease. SARS-CoV-2 is a virus. Also, it doesn't spread by just being near somebody. It will be, and she suggests that it will be nice to see some more for information resources on these items. So I wanted to give you that feedback. And when you asked about the languages, we had somebody mentioning Tagalog and Tigrinya. I hope I said that right. But I will forward you that information. Okay, I have one more question here. Has your organization created any videos?
No, we have not. So that's definitely something that has been that's been coming up. We have chosen to focus on kind of creating more handout style materials. Our initial vision for these was, they can be downloaded and physically handed out. So really getting at the idea of how would community organizations on the ground be able to best disseminate these materials. And for us, a very low tech solution was physical handouts that clinics could use, that physicians could use, etc. So that's why we chose to focus on more of the one-pager fact sheet route. But you're absolutely correct that videos would be an excellent supplement. We have not really had the bandwidth to integrate videos into our site, but we'd be very supportive of efforts to do so and willing to share if any of you have any recommendations for multilingual videos that we could promote on our channels.
Great, and we have a few more questions. Kristen Walker is asking, are the resources sheets with image and no text for non-literate people available on your website? Also, Tira Faison is saying that she's viewing your website. Where are the fact sheets without text?
Yeah, so both of those questions go together. And so the no text infographics were actually developed quite recently. So we actually have not had a chance to put them up on our website yet, but they will be up. Thank you for flagging that. They should be up by next week, or likely this week, honestly.
Great, thank you. And Suzanne Miro is asking, how long did it take from material development to sourcing these multiple languages to getting the materials launched?
Yeah, great question. Thank you for asking that. Honestly, I was so incredibly impressed by how quickly we were able to mobilize our coalition of students and physicians and reviewers. So from start to dissemination, it was a turnaround time of around 3 weeks for the vast majority of the languages. And of course, for some of the languages were added later, but we had the majority of languages up in from the time it took to create the fact sheets to promoting them and getting them into the hands of community members. It took around 3 weeks. So, when a pandemic hits, folks move quickly.
Yes, that's great. It's amazing how fast you and all the other medical students and partners that you have really got together and such a quick turnaround to really, you found a problem and you went straight for a solution because like you said, this is a fast moving situation that we have. Do you have any idea how many people you have reached with this information in 4 languages?
Yeah, so that's it's a great question. It's quite difficult to quantify, just given the different ways that we're disseminating the information. But I honestly don't have a number for you on that, just because it's a difficult question to quantify.
Of course. All right. If anybody has any more questions, we will still be open to answering them. In the meantime, I'm going to go ahead and show you a few more slides. We have our resources here. Obviously, like Pooja said, the CDC, the WHO are great for information on the most up-to-date evidence-based science on COVID. There is a link for the Health Literacy Project, Johns Hopkins. You will have a copy of this on your resources, and you're going to get it in your email, so you can click on this link. But the Johns Hopkins University has a live counting on how the virus is spreading around not just the country, but worldwide. And LEP Gov is a very good source for the limited English proficiency information. If you have any additional questions or you're interested in receiving individualized capacity building or training, please contact me or our department, sivasolutions@prostateeat.com, and follow us on our social media. Here's the information for Pooja and for the literacy program as well. Like you said, she's always updating things, and hopefully new things will be coming in the future. So please make sure you keep her. You will be receiving a short evaluation, so please take a few minutes after the webinar to complete it. This gives us great feedback and future information. And before we leave, I think we have one more question. Kristen Walker says Mandingo. She doesn't think she saw that on the list, but that will be a great other language to have in there. And if you could please, to conclude, describe your project social media efforts.
Sure, it's a great way to end. So I think, Joanna, if you don't mind going to the slide. Perfect. Yeah, that the slide with the social media handles. Actually,
yes.
Yeah.
Hold on, that's yours.
Perfect. Yeah, great. So regarding our social media efforts, we're on Twitter and Facebook. So you can see our Twitter handle is COVID-19 literacy, and our Facebook URL is also the same. So we would love for you all to connect with us on social media and help us amplify our efforts. Regarding our strategy for what we're actually doing on social media, what we do is we try to post our fact sheets in different languages on a daily basis to circulate information to folks who speak those languages. We try to tag organizations who serve those who speak that language, and thus gain momentum and amplify what we're already doing. We also highlight our partners and highlight the efforts that they're making to spread our fact sheets and spread our information to the communities that they work with. So again, really trying to just, amplify and connect with as many folks as possible. So we would love for you all to help us with that. I would also love for you all to connect with me on Twitter, and my email is also up there if you want to email me directly. Happy to field any questions offline. But again, thank you so much for having me. It's been a real pleasure to speak to you all, and looking forward to working with you all on this
I
important
do have one more question for you.
Oh, great.
It's a really good question that Judy Montenegro just asked.
Great.
And she wants to know, can you share the cost for agencies to replicate with local information?
Sure. So do you mean, what exactly does replicate by local information mean? Do you mean just to take this information and distribute to the communities that agencies are serving, or do you have something else in mind there?
Let's see if she replies a little bit, but I do want to remind that you mentioned that it is free to download the information that's on your website.
Yeah.
So while Judy elaborates, I wanted to go ahead and remind everybody that tomorrow we'll also be having puja on our Coffee House Wednesdays. So if you have more questions, if you forward this to other people and they want to come and ask more questions and share a little bit more with Pooja about your efforts and hers to spread the information for a limited English population, please join us tomorrow at 1 o'clock. We're going to be putting the link right now and sending you an email afterwards. Judy has not, but could you maybe elaborate on both? Like if somebody wanted to replicate?
Yeah, absolutely. And I think there's the answer is really it's free. We have not charged any organizations or any of our partners, any of the folks we work with, any amount of money for distributing our resources. So I would assume that replicating to or modifying to incorporate local information would be some quite minor changes, and it would be free. So for example, we're working with the Rhode Island Department of Public Health to make sure that the branding is consistent with theirs and include any local information that's specific to their state, and it's been entirely free for them. Like I said, our goal is not to put any sort of financial burden on an already stressed healthcare system, public health system. So all of our efforts, all of the partnerships that we formed have been free of cost. So.
Great, thank you so much. And let me check. I do not think we have any more questions as of right now, but thank you everybody for joining us. Please join us tomorrow. You can ask more questions, and if you have anything that you would like to get more information on capacity building or training, please do not hesitate in contacting me, and don't forget to please complete the short evaluation. Pooja, thank you so much for joining us and share this very important project that it's really life-changing for so many millions of people that feel that they're left out of such important information. Here's our link to meet us tomorrow on the Coffee House with Pooja. And if you have any other few words before we close, we are completely done. Thank you.
Thank you, Joanna, for having me. It's been a pleasure to be here.
Thank you, everybody.
Thank you all for listening as well.